madam, should we start with the next session?
Yes.
Okay. So,
Thank you so much for joining, and we are actually enjoying, and your inputs, your wise note, and your experience matters a lot. So please keep us pointing out wherever you feel it's appropriate. Thank you.
With this, we start with our last session, session 3, that is the panel discussion on difficult TLH. And the moderator for our session is Dr. Manish Pandya sir. I will briefly introduce sir. Sir is the professor and head of the department at Mahavir Hospital, Manish IVF Center, Sai Baba USG Center, and has multiple achievements and awards to his name. The Dynamic Indian of the Millennium by KG Foundation, Excellence Award by Foxy, and he has multiple publications and book chapters to his name. Sir, would you introduce the panelist, or would you like me to introduce the panelist?
You do the honors, madam, because you can see all.
Okay. Okay. So, I would like to introduce the panelists and welcome them on the platform. Dr. Shashank Shekhar.
बस मैं जा रही हूँ और सीमा को भेज रही हूँ, तो सीमा का लास्ट में बोलूँ, ठीक है?
So all the best, Sushila. Recently you had invented, क्या बोलते हैं? Recently you had invented the new techniques of using without mesh. So all the best. Jaipur Durbin Hospital is always progressing, and we are proud of you.
Thank you, sir. Thank you so much. Thank you.
Our first panelist is Dr. Shashank Shekhar. He is a professor at AIIMS Jodhpur, MD, MRCOG, DNB, and he is heading the unit in AIIMS. He has multiple awards and recognitions to his name. Our second panelist is Dr. Seema Gupta. Dr. Seema is a consultant at Jaipur Durbin Hospital and is also the editor of the book Step-by-Step Approach to Learning the ARG in Gynecoscopy. Third, we have Dr. Sejal Nayak, madam. Sejal Nayak, madam. She is a gold medalist, national coordinator, endoscopic committee, Foxy 2022-24, and she is also currently running for the post in Foxy. She's also received the Foxy Young Achievers Award and has been an organizing faculty for various national conferences in India. Next, we have Dr. Akansha Tripathi. Dr. Akansha Tripathi is working as a senior consultant laparoscopic surgeon in Udaipur, and she also has fellowship in infertility and ultrasound, and she's won a gold medal in Foxy quiz in AICOG 2010. And finally, we have Dr. Preeti Gupta. Dr. Preeti Gupta is an award-winning obstetrician for over 20 years of experience, and she has experience in as an infertility specialist and an endoscopic surgeon, secretary of Gwalior Obs and Gynae Society, and has been a faculty at AICOG and multiple state conferences. I welcome all the panelists, and Dr. Manish, the stage is for you.
Thank you, Sejal, for giving me opportunity. Is I audible?
Welcome everyone. Welcome, sir.
Good evening, sir. Good evening, ma'am.
Good evening.
Welcome, madam.
So Dr. Shashank is there. Dr. Shashank, Dr. Seema.
Yes, sir.
Okay. So thank you very much, Foxy Endoscopy Committee, for giving me opportunity to be on this platform. Today we are not just paneling, we are just discussing difficult hysterectomies. These are some of my credentials. Thank you for kind words, Chairperson. Welcome to this webinar. And I'm happy, I'm editor-in-chief of 2 journals. Those who want to become researcher, they can give me their research. This year
Sir, can we directly give you a call?
Yes, you can. So my first question is always praying to Sai Baba. This is one of the first slides whenever we play something. So play always Almighty. What is our first approach, madam? All the panelists, what is our first approach in difficult TLH? How we can go for first primary port? Anybody can answer this? Anybody can have this? Sejal?
Sir, first primary report according to the size of the uterus and depend on the previous history of any surgery, any scar mark on the abdomen.
Okay.
Uh,
So, any specific technique would you like to do for it?
Sir, at our center we prefer the direct trocar entry.
Very good, very good. And in which area would you like to put your direct
Sir,
trocar?
in normal size uterus, above the umbilicus, around 2 finger above the umbilicus, we prefer.
Okay. Sejal, do you differ?
Depending upon sir size, if at least 4 centimeter above the upper margin of the mass.
4 margin of the. Dr. Sashank? Hello?
Hi, hello. Hello everyone.
Yes, sir. Welcome, welcome.
Yes,
Yes,
sir.
yes.
Yes, sir. Welcome, sir.
Suppose this is our abdomen, this is umbilicus. We have got different because we are discussing difficult TLH, sir. Okay? So there is one palmar point. So, yes, sir.
Yeah, I would like to sort of categorize what is a difficult TLH.
Difficult TLH means it is not a simple TLH.
It could be previous surgeries.
Previous surgeries, previous 1 cesarean, 2 cesarean, 3rd cesarean, endometriosis.
It could be a hard uterus. That could be a difficult TLH.
Hmm.
I hope we are not getting into the domain of endometriosis. I think that's out
Okay,
of
that's we are not talking
It must be
endometriosis.
a large uterus or a scarred uterus or a scarred abdomen. And on a scarred abdomen, I always go by from Palmer's point.
Okay.
That's what I do.
This is your Palmer's point. Dr.
I
Sejal?
always scarred abdomen. I always take Palmer's approach.
Suppose there
And
is.
if it's a big uterus, I would like to keep at least 8 centimeter distance between the camera port and the top of or the fundus of the uterus.
Camera port and this is 8 centimeter.
4 fingers. So that will be roughly 4 fingers.
Okay. 8 centimeter you are covering.
Yeah. So my otherwise also in laparoscopy I go supraumbilically. Now the point is how do you go? If you want to go, either you can choose a leave once point, or what you can do is you can put a 5 mm trocar through the Palmer's point, and then you can decide where do you want to put your 12 mm or 12 mm prime B camera port in the midline. So you can decide. You can go into the peritoneum through the Palmer's point, and then you put your main camera port under vision.
So everybody agreed that in any difficult situation, primary port placement is utmost important because this is your gateway into the abdomen. This is how you know that what your secondary trocars will go. So primary port incision. Sejal, do you agree with all this point or you want to differ?
Sir, simple surgery can become difficult if your port placement is not correct.
You are not ergonomics. You are not following the physics. You are not following the
If
triangles.
difficult can
You are
be-
not following the triangles. Then you are in between the angles. Then you are in a soup. Is it right, Dr. Shashank? So your angle, just you said that 4 finger, 8 centimeter, you have to be ergonomics because this all laparoscopy in difficult surgery is about your ergonomics, your triangular management, your movement of your hands and your ease of movement. There should be no dandiya ras between the your instrument. You understand? If your instrument is playing the garba, then it is making difficulty. Do you follow garba, Dr. Shashank? In India we have got garba. So if your instrument is playing garba, then it is not good. Otherwise, in playing garba, the dandiya is good. Dr. Jaipur, would you like to add anything? Dr. Seema probably.
Yes, sir.
Would you like to agree with all these points?
Sir, yeah, I agree.
Okay. There is one different type of techniques I usually follow. This is a probably umbilical technique, and Dr. Rosa, I must mention that my first love is laparoscopy. My first book was published on step-by-step gynecological endoscopy out of 16 books published by JP. This is how we are doing our umbilical technique in any difficult situation also. Just palpating the umbilicus, taking the umbilicus, and we are giving local injection into the umbilicus. We all know that umbilicus has got all the parts stuck together. So we are cutting the umbilicus at the Langerhans line. We can see everything, and Dr. Shashank, you had just said by watching the peritoneum, we are just cutting the peritoneum, live and you put your trocar inside with the sleeve. We are just doing with this artery forceps and it will go inside. Believe me, whenever different surgeries are there for normal size uterus, I am not saying that big size uterus, normal size uterus can be assessed easily with this umbilical port, and if you wish to injure the viscera you can't. You can see we are going in. So this is very simple and safe technique. We are not using very since long. Now we are going for the first case, sir. This is a case with previous cesarean section. Okay, the same umbilical point we had used to go, and I had never found any adhesion in the umbilicus. Around the umbilicus it's good. I am using this vessel sealer. Do you agree that I should use vessel sealer or bipolar or harmonic? Dr. Shashank? Is this technique of doing this adhesinolysis is okay, or would you differ?
I don't disagree. You can choose any energy equipment, whichever
Okay.
you want to use, whichever you are comfortable with.
Okay.
Of course, you know, harmonic is a precise instrument for precise dissection. Even though I also use vessel sealer for retroperitoneal dissection, particularly the ligature, because the newer one has a, you know, the Maryland kind of
Yes.
job profile.
This is we are using Maryland.
It's okay. You're comfortable with it.
But if suppose this type of
But
thick
if there
thick adhesions are there,
then you could choose if the gut is very close to the you know, entrapped in the region, I'm sure
Yeah.
you would like to use a cold Caesar.
okay, that's good. Sejal,
Yes, sir.
you are using more of harmonics.
No, sir. I am majority using bipolar and scissors.
Bipolar and Caesar.
Yeah, but for dissection is definitely harmonic is a better dissector than any bipolar, and scissors may leave you with some oozing if directly cut you give, and then it will loss of the plane will be there. So for this kind of adhesions, a better use harmonic if the our
Because these adhesions are very thick, stuck near the anterior abdominal wall, even though she has got one cesarean section. What is the name of third panelist, madam? Sejal? Dr. Shashank?
Dr. Akanksha is there, Dr. Preeti Gupta is there.
Dr. Preeti Gupta, are you there?
Yes, sir.
Yes, madam, would you like to differ or it's okay?
No, it's okay, sir.
It's okay. So you will go very slowly and patiently on this patient to remove all these adhesions.
Yes, sir.
Dr. Jaipur?
Sir, we are using the bipolar shearer.
Okay.
And in case of the dense adhesion, we are using the cold seizure.
Okay.
And when we are cutting the adhesion, always look the window. There is a always transparent window.
Yes,
which
yes,
looks-
yes, fantastic. You can see there is a now the window has came. You see,
Yes.
now the window has started coming. So whenever this window coming, use that window to peep into the uterus.
Yes.
So if you see in somebody's window, it's not good. But in dissection, always choose the window to be used. Am I right, madam? हाँ, किसी के घर में झांकना अच्छी बात नहीं है, लेकिन ये विंडो से झांकना अच्छी बात है. So this is okay. Now we are coming on the second part of this previous cesarean section. How your approach towards the bladder dissection. Dr. Seema, Dr. Jaipur is Dr. Seema, na?
Yes, yes, sir.
Yes, Seema madam. Yes.
Sir, for bladder dissection, we should know the both approach, central and lateral approach.
Very good.
Yes, sir. Mostly we are using the central approach,
Okay.
and but in some cases we can use the lateral. So both approach should be low.
This is a lateral approach because there is thick adhesions over there. We can't find. There is no loose peritoneum over the bladder, so we are using it. And every time you are doing posterior dissection also, madam.
Yes, sir. We are doing the posterior dissection also in all cases.
Also. And at the level of uterine, Sejal, you are very fond of bipolar. I know during your surgery, at this level you are using bipolar only. Okay, so this bipolar at the uterine artery ligation is good.
Sir, I feel not in all cases you need to ligate the uterine.
No, there is no ligation. We are not ligating nowadays. After learning ligation from Dr. Rakesh Sinha, when we have got very good facility of good coagulation instrument like vessel sealer, harmonic, bipolar, shearer, we are not ligating it.
Hmm.
So you are not ligating, but you are using bipolar at this juncture, or would you like to use vessel sealer? You will see the bladder bulb is here, bladder is very far. We are dissecting bladder 2 centimeter or 2 finger breadth above the bladder dome. So we are on a safe distance. So always keep a safe distance towards your dissection. Dr. Sasank sir, your video has gone, sir. Okay, Dr. Preeti madam.
Still,
Yeah. Sir, what is your approach? This is the lateral approach by which we are dissecting very slowly. We are going step by step.
When we go, we would say, hi.
yeah, most of the
And I'm
times.
saying to him, David,
Yes, sir. Sir, you are muted one. Dr. Shashank, you are muted one.
Yeah, sorry. Okay, am I audible now?
Yes, sir.
Yeah, most of. So see, if very rarely you'll find that despite previous section, there is a good plane
Yeah.
between the bladder and the.
If we are lucky, then we find a good plane.
Otherwise, I always take the lateral approach.
Okay.
And there are certain tips I want to give you. When I do lateral approach, usually in an unscarred uterus, I first open after convoluted structure, I open the uterovesical fold. But I would, in previous section, it's a good practice to, first incise the posterior leaf of the broad ligament.
Yes, sir.
Because anterior compartment may not be very clear. So once you have, in previous cesarean section, always incise the posterior leaf of the broad ligament first. This gives you an idea about the isthmus where the vessels are. So you have to know in lateral approach, you have to stay anterior to the uterine vessel. That's the landmark that you have to bear in your mind. And that landmark become very clear when you do the posterior leaf in broad ligament dissection up front. And then you approach the bladder by lateral window technique.